Thank you very much for the introduction. It's always a pleasure coming to this meeting and being able to present. So today I'll talk about non-contrast MRA, kind of overview some of the techniques that are available for it. I won't cover all of the techniques. You've heard about some of them already, and you will hear more throughout the day. These are disclosures. So what is non-contrast MRA? So it's MRA without the use of any sort of intravenous contrast agents. It's predicated either on blood flow, or the physical properties like T1 or T2 of blood. It has a long history of development and predates contrast-enhanced MRA. It's particularly useful for patients who have present with severe renal impairment or when contrast should be saved for other purposes. And there are many techniques for performing non-contrast MRA. It's still developing, and we'll talk more about this throughout the presentation. First of all, I think it's important to kind of step back, get a little perspective on this topic, and pretty much just say that contrast-enhanced MRA is the preferred approach clinically. Provides excellent T1 contrast and reasonable scan times, and generally very good image quality with respect to in contrast with respect to background tissues. However, it's important to note that there are some concerns with the use of gadolinium-based contrast agents for MRA, and as well as iodinated contrast agents for CT. For instance, many patients with arterial disease also present with renal dysfunction. In the peripheral arterial disease population, this fraction is roughly 40%. And CTA poses the risk of contrast-induced nephropathy, whereas MRA poses the risk of nephrogenic systemic fibrosis, or NSF. And there are also some more recent concerns about gadolinium deposition in the brain as well as in the body. Fortunately, the risk of NSF has been virtually eliminated with simple precautions. Unfortunately, however, that administration of gadolinium-based contrast media is now viewed by many clinicians as unsafe and is not allowed by hospital policy for certain patients with renal impairment, and this results in a decreased use of contrast-enhanced MRA. There's also been some kind of a resurgence of interest in using iron-based agents recently, particularly ferriheme or ferromoxetol. It's considered to be safe in patients with severe renal disease, although there have been some severe anaphylactic reactions resulting in a black box label for the use of ferriheme. It is a true blood pool contrast agent, but it does have some drawbacks. Namely, it's very expensive. It's a therapeutic agent. It's not a diagnostic agent at present. It's not FDA approved for use as a contrast agent, and rapid infusion is also contraindicated. So we can't necessarily reproduce what we do with gadolinium-based MRA, where we imaged in the first pass. So this is a slide that overviews some of the non-contrast MRA techniques. I'll cover most of these today, not all. You will hear more about some other techniques throughout the day. So first technique is time-of-flight MRA. It's the most commonly applied non-enhanced technique clinically. It's primarily the workhorse when it comes to non-enhanced MRA used in a clinical setting. It consists of a flow-compensated gradient echo sequence and a continuous stream of radiofrequency pulses which saturate stationary background tissues and accentuate the signal of inflowing spins. Some general strengths of time of flight: it's widely available, easy to run. It's routinely used for neurovascular imaging. This is an example of 3D time of flight in the brain. Works very well there. Does have some drawbacks, mainly doesn't do a good job of, let's say, imaging the body, where the flow tends to be highly pulsatile, and speed of acquisition is not the fastest as well. Another approach is cardiac-gated subtractive MRA, and this is a cardiac-gated approach where the arterial contrast is based on different signal obtained at 2 cardiac phases. Specifically, arterial signal is retained in diastole when arterial flow is slow, and dephased in systole when arterial flow is fast, and subtracting these 2 volumes reveals the angiogram. Primarily implemented using 3D fast-spin echo-based imaging readouts. 3D balanced steady-state free precession readouts have also been reported. However, those are not commercially available. So just general strengths of this approach of cardiac-gated subtractive MRA. The FASP and echo variants are commercially available and provide sensitivity and specificities in the mid-80s for evaluating peripheral arterial disease. It offers a high degree of background suppression, but it does have some drawbacks. Primary drawback is that protocol tailoring is usually needed in patients with pathology. For example, one might need to adjust the trigger time and the degree of flow spoiling. It is also a subtractive technique, so if there's any sort of motion between the two acquisitions, that can result in misregistration artifact. Another approach is inflow-dependent inversion recovery, magnetic resonance angiography, and it's a technique that consists of three main events, the first of which is an inversion pulse, which is applied over the arterial bed of interest. This is an area that we want to image, and this serves to suppress background tissue. Second, we allow for delay time for fresh blood to flow into the target anatomy. And finally, we apply a flow-preserving readout, typically 3D balanced steady-state reprocession imaging, which provides a high signal from blood. So a main strength of this approach is that it has been shown to be accurate for detecting 50% or greater renal artery stenosis with sensitivities on the order of 87%, specificity of roughly 95%. It is commercially available, so it's potentially, at your institution, it's potentially usable by your physicians. Does have a weakness. It doesn't display slow flow very well because it relies on inflow, and this is a common kind of weakness of many of the inflow-dependent or flow-dependent techniques, non-contrast MRA techniques. Another approach is arterial spin labeled or ASL MRA, and you can think of this as kind of like a MR analog to conventional X-ray digital subtraction angiography, where the contrast is based on differential vascular signal imparted by differing RF pulses on the two acquisitions. Typically, the RF pulses applied on the labeled data set, we allow for inflow, and then we subtract the two volumes to generate our MR angiogram. Here are some examples. It can be used for static as well as time-resolved imaging of blood flow, as shown on the images on the right. Kind of general summary, provides really excellent arterial background contrast. Subtractive approach, there's no background signal if it runs properly. It can also be used for looking at time-resolved imaging of blood flow, potentially providing hemodynamic information. This is just an example of ASL, cine-ASL performed through a moderate renal artery stenosis. However, as many of the techniques, it doesn't work so well when there's very slow flow because it's inflow dependent, and it also is subtractive and is sensitive to patient motion. So another non-contrast MRA technique is quiescent interval slice selective, or KISS MRA. It was initially described for use in the lower extremity arteries. And it consists of a cardiac-gated 2D Cartesian balanced steady-state reprocession readout. There's some saturation pulses that are applied to suppress in-plane venous as well as fat signals. And typically, when imaging the lower extremities, roughly 400 slices are required, one slice in every heartbeat, to obtain a non-contrast lower extremity MR angiogram. So here are some examples of KISS as applied to the lower extremities. As you can see here, excellent correlation on the left panel with contrast-enhanced MRA. And it can also be used to acquire venography as well by basically just flipping the direction or the position of the tracking saturation pulse. So typically the tracking saturation pulse is applied below the imaging slice for arteriography, but it can be moved above the slice for venography. So the strengths of KISS are that it is accurate for lower extremity arterial disease at both 1.5 Tesla and 3 Tesla, providing sensitivities in the low 90s and mid 90s with respect to either digital subtraction angiography or contrast-enhanced MRA. It's fixed protocol There's no tailoring required in the lower extremities, and it depicts slow flow. It does have some drawbacks. Saturation of in-plane and retrograde flow can be seen at times, and image quality is not usually very good around metallic implants, for example, like hip replacements, because it uses a balanced steady-state reprocession readout. And it's a 2D technique, so slice resolution is typically limited to about 1.5 millimeters to 2.5 millimeters. But I think some of these drawbacks can be worked on, and I'll kind of touch some potential, I'll talk about some potential solutions later in the talk. So those were some of the non-contrast techniques that that exist. I didn't cover all of them, but at this point of the talk, I'll talk about how non-contrast MRA can sometimes provide more information than contrast-enhanced MRA. And this is a case of a 51-year-old male with a history of elevated cholesterol and triglycerides, who presented with new onset right calf claudication and an abnormal ABI as well. So this patient was imaged with time-resolved contrast-enhanced MRA, and mild stenosis was seen in the distal right popliteal artery. With non-enhanced KISS MRA, where we noticed some high intramural signal, and this high signal was not noted on the contrast-enhanced MRA exam. And this prompted additional scanning with T1 and T2 sequences, where the diagnosis of cystic adventitial disease with intramural hematoma causing arterial stenosis was made. Also, non-contrast MRA can, you can use it as a fallback to contrast-enhanced MRA. So this is an example of a patient with an abdominal aortic aneurysm, and with contrast-enhanced MRA, we didn't see the pelvic arteries very well because the bolus was essentially slowed down by this aneurysm, whereas where we ran the KISS study, it only requires minimal inflow, we saw these pelvic arteries very well. This is another example in the neurocirculation, where we saw considerable venous contamination from late imaging with respect to the first passage of the contrast bolus, whereas we can use a non-contrast MRA exam if used as, for example, a scout to see the anatomy as well as a fallback exam. Another, I think, topic we should discuss here is that vascular calcifications are an important component of vascular disease, and with CT, we can often see calcifications very, very well. And so in this patient, had extensive vascular calcifications, and with CT, though, this obscured the lumen and made it difficult to see the anatomy. Whereas with MR, we didn't see any of these calcifications. So the study was fully diagnostic, but we were missing this piece of information. So why is this important? Well, calcifications, the presence of calcifications are important to know about because we need to identify them prior to vascular interventions. And calcium imaging is easily done with CTA, but not with MRA, as shown here, where we see calcifications very well on the CT exam. There's no such information on the MRA exam. However, if we apply other imaging sequences, notably this proton density weighted in-phase Stack-of-Stars flash acquisition, and project the data using a minimum intensity projection, we can see the vascular calcifications very well in a projection format, similar to how we view them with CTA. And this approach is found to be an excellent agreement with CTA for quantifying vascular volume, calcification volume, excuse me. So this is just some examples of showing how we can see vascular calcifications with MR for very, let's say, severe lesions on the panel on the bottom, and even for small isolated calcifications as shown here. So I talked about some of the basic techniques earlier in the presentation. I think it's important to talk about promising recent developments in non-contrast MRA, to kind of set the stage for where we are going, potentially what the future holds, and engender a sense of, let's say, basically suggest that it's a developing field and there's more to come, and we'll likely see newer and better techniques as we move forward into the future. So one potential new development is the use of non-Cartesian sampling and non-balanced steady-state free precession imaging sequences, in particular 2D radial KISS and 3D Stack-of-Stars KISS shows substantial potential here. Also the use of flash instead of balanced steady-state free precession imaging sequences for imaging patients with metallic implants, as well as the potential of new steady-state imaging readouts that promise high signal-to-noise ratio with reduced flow artifacts and intrinsic fat suppression. So here are some examples of 2D radial KISS MRA. The image on the right, actually in the pulmonary arteries, is radial true FISP, where we can see very nice image quality, all without the use of contrast media. And so what are the advantages of radial sampling in comparison with Cartesian sampling? Well, in our hands, we found that it provides more uniform arterial signal, especially when we try to image without cardiac gating. It also avoids ghosting in the phase encode direction, as well as wrap in the phase encode direction that we often see with Cartesian imaging. And it just naturally supports higher undersampling factors and allows us to shorten our acquisition times, making these techniques more tolerable for patients and ultimately more these techniques to be better fits for potential use in a clinical setting. Also, 3D Stack-of-Stars trajectories show a lot of promise. For example, there's potential for shortening scan times. This is an example where we required a breath hold Stack-of-Stars acquisition to demonstrate the renal arteries in 18 seconds, compared to kind of the more conventional free breathing inflow-dependent inversion recovery acquisition shown in the center, which took 4 minutes. There's also potential of 3D Stack-of-Stars non-contrast imaging for providing smaller voxels and better image quality than 2D KISS, is shown here for imaging the entire neck. We could also use flash readouts. Flash readouts are a potential alternative to balanced steady-state free precession imaging readouts in that they help reduce magnetic susceptibility artifacts. So this is an example of a patient who had a hip prosthesis. KISS, using a balanced steady-state free precession readout, showed substantial artifact here. This artifact was eliminated with the use of a fast slow angle shot readout. We can also look at new steady-state imaging sequences and radial fast interrupted steady-state FISS imaging. We found it to be very useful for ungated, non-enhanced imaging of the lower extremities here, as shown on the panel on the left. So this is completely ungated. No cardiac gating was involved in acquiring this lower extremity MRA angiogram. When combined with arterial spin labeling, we can get dynamic visualization of flow with high temporal resolution as well as spatial resolution. And I think I've already shown this example. We can use this approach for 3D imaging in the abdomen with an intrinsic fat suppression, as shown here in this 18-second breath hold exam. So some additional promising developments. There's been some work in the using ultra-short echo times to reduce artifacts in the brain for MRA near stents, as well as other metallic implants, whether it be coils. There's also potential for incorporating acceleration strategies into our imaging techniques, and we'll likely see more of that in non-contrast MRA and hear more about that throughout the day. Also, there's great opportunity to leverage artificial intelligence, whether it be through diagnosis, image reconstruction and enhancement, and or automated image and data processing and analysis. So in conclusion, there are many techniques. Largely, the clinical need and the vascular bed of interest drives the techniques that's selected. Non-contrast MRA does have some drawbacks. It's less robust than contrast-enhanced MRA. Is longer scan times. There's potential for diminished accuracy historically and a tendency to overestimate disease, although some of the newer approaches, this kind of drawback is being addressed. Metallic implants also degrade image quality, although these can be ameliorated with the use of flash readouts. So what are the strengths? Eliminates the risks and costs associated with gadolinium-based agents, can provide an accurate diagnosis in many patients. It's repeatable, unlike contrast-enhanced MRA, and can serve as a fallback exam. And it sometimes can provide more information than contrast-enhanced MRA, clinically useful information, as we've seen in the course of the talk.